Today with the small intestine and the pancreas. Just a few words about the pancreas. It's it's both exocrine and endocrine gland, right? It's comma shaped, located between the two arms of the duodenum. This is the duodenum here, and this is the pancreas. Goes between the two arms of the duodenum all the way to the spleen. Spleen will be here, right? It is sitting on the posterior abdominal wall, and it's one of the retroperitoneal structures. Do you know what retroperitoneal means? Yeah, so it's basically they are not devoid of peritoneum. Peritoneum is like a towel, it passes on top of them, covers them anteriorly. And these basically are the structures that are sitting on the posterior abdominal wall. What do we have? We have the kidneys, right? We have the duodenum, we have the pancreas, we have the psoas muscles here, we have the inferior vena cava, we have the aorta. So these are the retroperitoneal structure. Pancreas is one of them, except the tail of the pancreas. Why the tail is not retroperitoneal? Because it's sandwiched between a ligament. We have a peritoneal ligament between the kidney and the spleen. It's called splenicorenal or lieno-renal ligament. So pancreas is a retroperitoneal structure except for the tail that is sandwiched between the two layers of splenico-renal ligament. You know, whenever we have a two-layer fold of the peritoneum, either we call it a ligament, peritoneal ligament, or we call it a mesentery, or we call it an omentum. Okay, so the pancreas has a head. Okay, you can see the head here. And there is a little extension here to the left. It's called the uncinate process. And it can be identified here because it is crossed by these vessels. These are the superior mesenteric vessels, artery and vein. So the part of the pancreas, of the head of the pancreas that goes a little bit to the left hand is crossed by the superior mesenteric vessels. It's called the uncinate process. And then we have the, of course, you know, anterior to the head, you will have the transverse colon and mesocolon, the mesentery that attaches the colon to the posterior abdominal wall. Posterior, you have the renal vein, and as we discussed in my lecture this morning, we have the common bile duct. Uncinate process, I mean, the neck is the constricted part here, and it is important because we're always going to say behind the neck of the pancreas, we have, you know, the portal vein starting, or it starts. It's, you know, union of the splenic and the superior mesenteric vein. They unite just behind the neck of the pancreas. And then we have the body and the tail. Nothing much to discuss about the pancreas in terms of anatomy. It's more important physiologically. Of course, blood supply, we have the splenic artery. Splenic artery is one of the branches of the celiac trunk. You know, celiac trunk, gut is divided into foregut, midgut, hindgut. Foregut will be supplied by celiac trunk. One of the main branches of the celiac trunk is the splenic artery. Once you see the splenic artery, you will not forget it ever, will not be able, because it's huge, thick, tortuous, and it is dancing on the upper border of the pancreas. So it's going to go here, will be thick, you're going to see it going towards the spleen. And also the pancreatico-duodenal arteries, one of them is going to come from the celiac, one of them is going to come from the superior mesenteric. We'll discuss the whole blood supply of the gut in one full lecture. I'm assuming also they are discussing that in the lab, but I have, you know, my way of explaining the blood supply to the gut. It's better to talk about it in one piece. Lymphatic drainage, of course, you follow the arteries, and you know, you will have lymph vessels that will follow the arteries and will drain into the celiac and the superior mesenteric. Nerve supply, it is a viscera, sympathetic and parasympathetic. To me, physiologists will talk about it, but to me, I'm more concerned about the afferent fibers, meaning the pain fibers coming from the pancreas and going to the spinal cord, how they hitchhike with the sympathetic fibers. We'll talk about that and the concept of referred pain at the end of this lecture. As we said in the morning, pancreas has an exocrine function where it secretes enzymes and substances needed for digestion, right? And that needs to go to the small intestine. So we have to have a duct or ducts. The main pancreatic duct is duct of Wersung. This is the main pancreatic duct. And it joins the common bile duct, forming the ampulla of Vater. Ampulla of Vater is going to be surrounded by a sphincter of Oddi that's going to go into the second part of the duodenum, as we're going to see in a little bit. Now, the small intestine is about 6 to 7 meters in length. And then we have additional 2 meters of large intestine. So you will have inside your abdomen, close to 8 meters of coils of intestine. Small intestine has 3 parts: duodenum, jejunum, and ileum. Duodenum is the shortest. It is this one here. It is C-shaped. It's about 10 inches in length. And it is C-shaped, between the 2 arms, we have the pancreas divided into 4 parts: first part, second part, third part, and the last part. Now, the duodenum is one of the retroperitoneal structures, except the first inch of the first part. Now, the first part is 2 inches. The second part is 3 inches. The third part is 4 inches. And the last part is 1 inch, okay? So 2, 3, 4, and then finally 1 inch. So the first part is 2 inches. Only the first part is covered by peritoneum. Why? Because we have this. Now, what is this? What do we call that? Lesser omentum, right? The 2-layer fold of the peritoneum extending between the lesser curvature and the liver. This part of the lesser omentum is called the hepatoduodenal ligament. Hepatoduodenal ligament is very important. Why? Because it contains 3 important structures that goes into the liver or leaves the liver in the porta hepatis. What are the 3 structures? Hepatic artery going up, portal vein in blue going up, and the common bile duct, going down. Okay, so these are the 3 structures in the hepatoduodenal ligament part of the lesser omentum. What do we have behind the lesser omentum and behind the stomach? Lesser sac. Why do we need a lesser sac? What is a lesser sac? It's part of the peritoneal cavity, right? You imagine you have a balloon, and you twist the top of the balloon. You have a tiny little cavity and then the bigger cavity. The whole peritoneal cavity is the big one. The smaller one is situated behind the lesser sac and the stomach. Why do we need it? So that the stomach can expand. Now you can actually put your fingers here and enter into the lesser sac. This is called the epiploic foramen. So in the lab, inshallah, tomorrow for some, they will identify that for you. They will ask you to put your fingers, and sometimes surgeons, they need to clamp the structures that are here between the thumb and the index finger. Okay, so this is the epiploic foramen. Now, back to the first part of the duodenum. The first part is 2 inches. First inch is wrapped by the hepatoduodenal ligament, and then the rest of the duodenum is retroperitoneal. So this is the first part. As we said, it is 2 inches. And, you know, if I would let the liver go, for me to be able to see it, I had to lift the liver. If I let the liver go down, so the first part of the duodenum will be in touch with the quadrate lobe and with the neck of the gallbladder. Now, what goes, and this is important, what goes behind the first part of the duodenum going down or up? We have the portal vein, right? We have the common bile duct, right? And the hepatic artery goes up, but we have an artery that goes down, opposite to the hepatic artery. You know, common hepatic will divide into two branches. One goes up towards the liver, hepatic artery proper, and one goes down, which is the gastroduodenal artery. There's an artery that goes down, it's called the gastroduodenal artery. Remember in the morning I said, if you have an ulcer in the posterior wall of the duodenum, you know, it might erode through the mucosa and the muscles and actually erode through the artery, causing severe bleeding. So posterior to the first part of the duodenum, we have the lesser sac, we have the gastroduodenal artery, we have the bile duct, we have the portal vein, and the inferior vena cava. Superiorly is the epiploic foramen here. Inferiorly, what do we have? We have the head of the pancreas. So this is the first part of the duodenum. Inferior to it is the head of the pancreas. As you notice here, what attracts your attention in this picture? Yes, the first inch of the first part is smooth. Mucosa is not full. So if you ask the patient or, you know, any individual to drink that barium thing, you know, the barium is substance the patient we ask to drink and will be excreted as is without absorption. And then we start taking pictures to see the contour, the structure. You know, barium will be smooth here. While once we get past the first inch, it will start to be broken. Why? Because we have mucosal folds in the duodenum, and for the rest of the small intestine, we call them plica circularis. So these mucosal folds are called plica circularis. Now the second part of the duodenum, as you can see here, is in front of the kidney. So posterior to that, you will have the kidney, right kidney, of course. And if I let the liver go down here, so again, it will be in touch with the second part of the duodenum. So, and, you know, the gallbladder and, you know, the right lobe of the liver, and of course, the transverse colon will be anterior to the second part of the duodenum. Second part is 3 inches. You add 1 inch, okay? Now, what is special about the second part? You know, remember that we have the pancreatic duct will be joining the common bile duct, forming the hepatopancreatic ampulla of Vater. Now that is going to be surrounded by a sphincter of Oddi. Now the two, which is basically the ampulla of Vater, they're going to bulge into the posterior medial wall of the second part of the duodenum, right? When they enter, they're going to push the mucosa, creating something like a little ball. It's called the major duodenal papillae. Okay, so this is the major duodenal papillae. Basically, you know, it signifies the entrance of the ampulla of Vater into the duodenum. Why did we call it major? Because we have a minor. What is the minor? Now, we have a main pancreatic duct of Wersen. Some people might have an additional pancreatic duct. It's called duct of Santorini. Now, if we were to have this additional duct, it will open again in the second part of the duodenum, but about 1 inch above the major duodenal papillae. And because it is small, not like the ampulla of Vater, you know, it's going to create a little ball. We call that the minor duodenal papillae. Third part is going to be extended between the psoas muscle to the other psoas muscle. And remember this, whenever we say psoas muscle, by default, you have to imagine we have the ureter running on psoas muscle always. We have the gonadal vessels on the psoas muscles, meaning testicular vein, the vein that goes to the testicles in males, or ovarian vein that goes to the ovaries in females. So it extends, it's 4 inches, goes from psoas muscle over the inferior vena cava, over the aorta to the other psoas muscle. Okay. Now, we'll talk about that later. It is crossed by the root of the mesentery. Now, the last part is the shortest part of the duodenum, is the ascending part, and it's only 1 inch, small part before the jujunum starts, and it is attached to the diaphragm by a peritoneal ligament that attaches it to the right crus of the diaphragm. It is attached to the diaphragm by a ligament of Treitz, just, you know, to the side or to the left side of the abdominal aorta. So this is the duodenum, C-shaped, 10 inches, first part, second part, third part, and the last part is the fourth part, 1 inch. And now in this picture here, where is the duodenum? Where is the duodenum here? It's not seen, right? This is the jujunum. This is the beginning of the jujunum. Why it's not seen? Because it is retroperitoneal. So for you to be able to see it, you have to open the peritoneum here. Okay, but the rest of the small intestine is divided, or it has 2 parts, the jujunum and the ileum. The jujunum will occupy the upper left part of the abdomen, while the ileum lower, you know, right part of the jujunum. Jujunum is about 2/5 of the small intestine, and it comes to about 8 feet. Now, we're talking about 6 to 7 meters of small coils of small intestine. Are you going to allow them to float freely in the abdomen and swim wherever they want? Yes? No? Why? It's now the era of freedom. Or we're going to have to restrict their mobility. Why do we need to restrict the mobility? Huh? Why? Herniation. Now imagine you have a hose of 6-7 meters and start playing with it, just throwing it. Will coil, will tangle, right? So if it goes around each other, you will have ischemia because it will take blood vessels with it, right? It will tangle blood vessels with it. So you need to bring these 6-7 meters of coils of small intestine and bring them together, limit their mobilities. How do we do that? We wrap them by peritoneum. So we have 2 layers of peritoneum because they wrap all the coils of intestine, and what do? They attach them to the posterior abdominal wall. So this is the mesentery of the small intestine. Why do we need a mesentery? Number 1, to hold the coils of intestine so they don't tangle. Number 2, they contain, between the 2 layers, they contain the blood vessels, nerves, and lymphatics, and so on. So this is the mesentery of the small intestine, which is this. Now this 6-7 meters here, they are all brought together and they are attached to the posterior abdominal wall. We don't call a mesentery as a mesentery unless it is attached to the wall. If it is not attached, like the one that the appendix has, we call it false mesentery. Okay, so the mesentery that brings the coils of the small intestine and attach it to the posterior abdominal wall, we call that the mesentery of the small intestine. Now, the line of attachment, you bring the 6-7 meters and attach them to this small area between L2 on the left and the sacroiliac joint on the right. It's about 15 centimeters. This line of attachment of the mesentery to the posterior abdominal wall is called the root of the mesentery. Okay, it starts from the duodenal junction to the sacroiliac joint at about, obliquely at about 45 degrees. Okay, now this root of the mesentery is the length is about 15 centimeters, and between the attachment to the posterior abdominal wall and the wall of the intestine is about The depth is about 20 centimeters. And of course, the length is, matches the length of the small intestine. Okay, so mesentery of the small intestine, bringing the cords of the intestine, attaching them to the posterior abdominal wall. And this line of attachment is called the root of the mesentery. It's about 15 centimeters in length. The depth between attachment and the intestinal wall is about 20 centimeters, and the whole length is 6 to 7 centimeters. Now, this root of the mesentery will be here. So it will be crossing the third part of the duodenum. It will be crossing the aorta. It will be crossing the inferior vena cava. It will be crossing the psoas muscle. And when we say psoas muscle, also the ureter and the gonadal vessels. Okay, here, where it crosses the third part of the duodenum, it contains the superior mesenteric vessels. These superior mesenteric vessels, they are big, they are huge because they supply, most of the intestine. Okay, so that's why we have a mesentery. It contains blood vessels, it contains nerves, it contains lymphatics. Now, if you were to operate on ileum, for example, and you're a surgeon, how you know that these coils are for the jujunum, these coils are for the ileum? You're going to pull the 6-7 meters out, or you have ways of differentiating between the two. There are external differences between the jujunum and the ileum. Now, jujunum is wider and thicker and redder. Why is that? Because it has abundance of this. What do we call these mucosal folds? Plica circularis. Now, in the area of the jujunum, they are thick, they are dense, they are abundant, giving the jujunum, this thickness and this redness. And remember the barium, the white material that the patient drinks, if you do that, this is the area of the jujunum, it is broken, it's not smooth. As you go down towards the ileum, we have much less plica circularis, and they are not as thick, and that's why the barium here in that area of the ileum is smooth. Okay, so that is number one difference. The other thing, now in the mesentery, we have the blood vessels, and these blood vessels, they arch, forming arcades or loops. The area between the loops is called lunate. I have it, yes, lunates. Now, in the area of the jujunum, we have fewer arcs or arches with long terminal vessels. As you go down toward the ileum, these arches become more, and we have short terminal vessels. So that is difference number 2. Now, difference number 3, and which is something that you're going to see in the lab, the 2 layers of the mesentery are between the 2. We have blood vessels, nerves, lymphatics. You need to protect them, so you fill that with fat. It's filled between the 2 layers, filled with fat. In the area of the jujunum, fat does not go all the way to the wall of the intestine. So what they're going to do in the lab, they're going to hold the coil of jujunum and they're going to put their hand behind it or shine a light. You can see their hand behind the coils of the jujunum, because fat does not go all the way here. While in case of the ileum, fat goes all the way to the border of the wall of the intestine. So if you put your hand behind, you're not going to see it. Okay, this is an experiment they're going to do in the lab. So 3 differences: the jujunum is thicker, redder, and wider. Number 2, we have these arcades or arches with long terminal vessels. As you go more towards the ileum, these arches will be more. So here, if you have 1 or 2, there you will have 3 or 4 arches and short terminal vessels. Difference number 3, fat does not go all the way to the wall of the jujunum, but it goes all the way to the wall of the ileum. And internally, if you were to open the ileum, you will find these structures. These are lymphatic tissues. We call them Perry's patches. They are present on the anti-mesenteric border. What is anti-mesenteric border? The border that is not attached to the mesentery, the opposite one. And they are only found in, or more abundant in the ileum. They are part of the lymphoid tissue. Lymphoid tissue plays, like your lymph nodes, your spleen, and in other places, it plays part in your immune system. Okay, now what did we say about the muscular layers of the gastrointestinal system? We say we'll always have two layers. Outer longitudinal, like a spring, and the inner circular for peristalsis. Now, in the area of the small intestine and in the large is different. In this area, we have two complete layers of muscles surrounding the wall of the small intestine, outer longitudinal and inner circular. When we talk about large intestine, we still have the two layers, but the arrangement is different. We'll talk about it later. Meckel's diverticulum. Now, during embryonic life, there is a connection between the primitive gut that later will develop into the intestine and the yolk sac. It appears, around the 4th week, and then it should disappear around the 7th week. But sometimes it might remain. If it remains, it might remain as a, diverticulum, similar to the appendix, or diverticulum with fibrous cord, or as a fistula meaning it is open in both ends, so intestine with the umbilicus, and whatever you have in the intestines can leak through the umbilicus. Sometimes it's just a cord, sometimes we have a cyst, sometimes it is a sinus, it's open from one end. So today we'll talk about the Meckel's diverticulum. Meckel's diverticulum is a remnant of the vitello-intestinal duct that connects the primitive duct with the yolk sac. It should disappear by the 7th week. If not, it might be left as, Meckel's diverticulum. Why Meckel's diverticulum? Why I'm mentioning it? Because it might cause the same signs and symptoms if inflamed like the appendix, but the appendix will be on the right side, Meckel's diverticulum will be on the left side. So how common? It is present in 2% of people, where it is 2 feet away from the ileocecal junction. So where the ileum joins the cecum, you move backwards about 2 feet, it should be around here. And it is 2 times as common in males than in females. And we have 2 types of ectopic tissue, gastric and pancreatic. So it is the rule of 2%, 2 feet, length is 2 inches, but these things are variable, but these are the common things about the Meckel's diverticulum. In 2% of people, 2 feet away from the ileocecal junction, and length is about 2 inches, 2 times more common in males, and we have 2 types of ectopic tissue sometimes in it. What is ectopic tissue? Shabab, what is ectopic tissue? أسفين صحيناكم النوم بس إيه؟ Yeah, it is a tissue that's present in a different location where it's supposed to be. So, for example, gastric is supposed to be in the stomach, but in this case, it might be present in the Meckel's diverticulum. Pancreatic tissue is supposed to be in pancreas. In this case, Meckel's diverticulum might contain pancreatic cells. So if you have gastric cells or pancreatic cells in the Meckel's diverticulum, so what's the big deal? Shabab, what's the big deal? What gastric cells will secrete? secrete acids and enzymes for digestion. What pancreatic cells will secrete? Pancreatic juice, that is, If you have that in the Meckel's diverticulum, then they are prone to ulceration, similar to gastric ulcer, perforation if it becomes deep and bleeding. And sometimes, in the wall of the diverticulum, there's a weakness in the muscular layer. So it forms like these little appendages. We call them diverticuli. And sometimes they become inflamed. We call that diverticulitis. For example, on this X-ray, you can see here a diverticulum, that's another diverticulum, that's another diverticulum, and so on. So complications of Meckel's diverticulum: diverticulitis, diverticulosis, ulceration, perforation, and bleeding because of the presence of the ectopic, gastric, and pancreatic tissue. Now the concept of, and I said I'll talk about it, of referred pain and what does it mean. Now, as I said in the morning, you've never experienced a situation where you said, oh, I have pain in my appendix, or I have pain in my ureter, or I have pain in my heart, right? On daily basis, never. But on daily basis, you might be hit by a table, somebody hits you, somebody punches you, and so on. So your central nervous system is used to receiving pain signals from the outside, right? How frequent do you receive pain fibers from the heart? Now, before we go to that, I know you had, now this is the fun part. Let's forget about this. Now, what types of sensation you feel or organs feel? Now, if I bring a knife and start cutting your liver, oh, that's gross. Huh? Start chewing your liver. Do you think the patient will feel anything? No? Yes? No? Yes? Now, if I bring a cautery, what is a cautery? The thing that burns the blood vessels to stop bleeding. And I start burning your uterus or your kidneys. Do you think a patient will feel anything? Yes or no? Have you tried that? How do you know? Guys, you had a lecture on autonomic nervous system function and structure, right? So simple question. Of course, we have sensory. Now, what types of sensation that a viscera would feel? What type of pain? Sharp, electric, huh? So I'm asking you a simple question. If I cut your liver with a knife, would the patient feel anything? Since I'm asking this question, the answer should be no, because if yes, then I wouldn't be asking you this question. No, the answer is no. Now, there are two types of sensation: somatic, like your skin, you feel pain, touch, temperature, right? And there is visceral or autonomic. Organs, they feel what type of sensation? Ischemic or stretch or distension. For example, if you go, you want to do endoscopy, so the physician can see clearly, they inject gas. Gas will distend the colon or whatever, the intestine, and patient will feel pain. Otherwise, you don't feel pain as we know it. You don't feel any kind of pain, except for ischemic pain. You have the heart, you cut the heart, patient will feel nothing. You burn the heart, patient will feel nothing. But if you cut the blood supply, you will have a severe pain. That is called ischemic pain because, you know, you feel it because due to accumulation of metabolites. Anyway, that's not our topic. So organs feel ischemic pain and stretch and distension. The rest, no. Right? For example, the vagina, when we talk about repro next year, the first 2 centimeters are really painful because they are supplied by a somatic nerve. The rest, autonomic nerve supplied, you do whatever you want and the patient will feel nothing. So autonomic nervous system, sympathetic, parasympathetic, you know the function. Now what really matters to me is that pain fibers from these viscera or organs, they have to have access to your central nervous system. Otherwise, how are you going to tell your spinal cord and brain that, okay, I have something wrong in my heart, I have something wrong in my kidneys, they have to gain access to your spinal cord. So normally, whatever pain that reaches the brain and spinal cord is going to think, you know, it is coming from the wall because that is the daily event. We'll never think this is coming from the heart or this is coming from the kidney or this is coming from the gallbladder and so on. Now, from the wall, what are the nerves that will carry this sensation to the spinal cord? We call them spinal nerves. And it is known that this spinal nerve, this spinal segment, this segment of the spinal cord will bring pain sensation from this particular region. We call that dermatomes. Spinal cord is divided into segments, 31 segments. Each segment has 2 spinal nerves, one for the right, one for the left. And each spinal nerve will bring sensation and will send motor information to specific parts in the body. And we know, we call this area of the skin supplied by specific segments or spinal nerves, we call them dermatomes. For example, and I know this area, for example, around the umbilicus, it's supplied by T10, meaning the thoracic segment of the spinal cord, number 10, is responsible for receiving sensation from the area around the umbilicus. This is called dermatome. This area is supplied, you know, by C2, C3, C4, and so on. They are well defined. This is L1, this is L2, well defined areas supplied or receive sensation from specific spinal nerves. Now, how am I going to relate this to the pain fibers coming from the organs? Now, when we said the liver, it received parasympathetic vagus and we receive sympathetic coming from T5 to T9. What do they do? You know, what do they act on? Smooth muscles, right? We leave that to the physiologist. I said, I'm interested in the pain fibers coming from the liver. They will hitchhike back with the fibers coming from T5 to T9 because they want to gain access to the spinal cord. Where are they going to enter the spinal cord? Which segments? T5 to T9. So your spinal cord is going to think pain is coming from where? From T5 to T9. Where is the area of T5 to T9? This is the area of T5 to T9. So pain from the liver is going to be felt in that region. Okay? And I have here the shoulder highlighted. Why? Gallbladder receives T7 to T9, which is basically the same area, but it also receives signals from the phrenic nerve. Phrenic nerve is C3, 4, 5, right? Phrenic nerve. Heard about phrenic nerve? Anyway, it's coming from C3, 4, 5. Where is the area of C4, 3, 4, 5? This area, the shoulder. So pain coming from the gallbladder, the patient will come and say, I have pain here, and it radiates, also it goes to my shoulder. What is the relation between shoulder and gallbladder? You know, because phrenic nerve that supplies the capsule of the peritoneum covering gallbladder, is coming from C3, 4, 5. This is the concept of refer pain. Patient does not come and tell you, I have pain in my heart. Will tell you, I have pain in my left side of the chest, going to my shoulder. Why? Because it's, the nerves that bring nerve pain sensation from the heart, they enter the spinal cord as, cervical areas, C3, 4, 5. Okay? Similarly, the pancreas, when we said, supplied by sympathetic T5 to T9, referred pain is going to go to T5 to T9. So pancreatic pain will be felt here. Okay, this is the concept of referred pain. Ureter, they're going to come from L1, L2. So why a patient with, stone that is going through the ureter is felt here? What is the relation between here and the kidneys or the ureter? What is the relation between here and the appendix, for example? This is the concept of referred pain, because nerve fibers coming from that organ enter specific spinal segments. So your brain is going to think it's coming from the outside. Okay? This is the concept of referred pain. So whenever I ask you what is the nerve supply of the liver, sympathetic, parasympathetic. I will not go very specific probably and say which segments of the spinal cord. You're going to tell me T5 to T9. Right? Why it is important? Because it will tell me where the pain fibers will go. As simple as that. Okay, any questions on the small intestine?
Doctor, you said that the organs will stretch and be on the body, right? If, for example, we cut the heart,
You will feel nothing.
not even on the body.
Not even on the body. But if it is ischemia, it is severe pain.
And you'll feel it like on the arm.
Yes, you feel it like on the arm, on the shoulder, and the left side of the chest. Okay? And they do that. They go into the uterus, they do the, cleaning, curettage, or whatever, or cautery, and the patient will feel nothing except the first 2 centimeters. Any other questions? So in TBL2, we'll, ask you about this.
I have a question about the minor intestinal. Can you go back to the slide?
Now, what's your question?
Question is that, is it
Yes? No. No, I told you, some people might have an additional pancreatic duct, which is this one, Santorini. If they were to have it, then you will have the minor duodenal papillae. What is a papillae? It's basically when the duct enters into the duodenum, it pushes the mucosa. It bulges to the outside. So this is the minor duodenal papillae, only if we have the additional pancreatic duct of Santorini. Okay? Been a long day for you guys.